My name is Amy Escott. I'm the project director of the Missouri Academy of Child Trauma Studies.
And hi, I'm Kate Drury. I'm the manager of clinical services at Children's Advocacy Services of Greater St. Louis, and I'm also an approved trainer for trauma-focused cognitive behavioral therapy.
So we are so glad that everyone is joining us today. I know we've been talking with people over email and over phone, and our goal today is to give you more information about the project and the application process and what TFCBT is like. But before we jump into that, we have some of our participants who are joining in by web, and we have some of our participants who are joining in by the phone. And throughout this process, we will give you opportunities to ask questions and address as many of those questions as we can. If we don't have time today, then you can feel free to reach out to me or Kate or anyone on our training team after the webinar, and we'd be happy to answer whatever questions you might have. So first, we wanted to do some thank yous to Kelly Gregory with the Missouri Institute of Mental Health for hosting us today, and Kirsten Brunig, who's also helping us as well. You may have received information from our logistics coordinator, Stephanie Lane, so thank you to all three of them for helping make this possible. And then we wanted to start off by saying another big thank you to the Missouri Children Trauma Network, as well as the Missouri Coalition for Community Behavioral Healthcare for sponsoring this training, and the Learning Collaborative, and for their help in promoting this event. So in case you are unfamiliar, the Missouri Child Trauma Network is an organization of clinicians and advocates from across the state of Missouri who seek to increase access to evidence-based mental health services for children and families. And so they do that by providing training for clinicians in evidence-based models, helping to identify screening and assessment, and helping to also collect data so that we can then take data back to our funders to help demonstrate the effectiveness as well as the need for evidence-based practices in Missouri. And so with that in mind, Kate and I are part of the Missouri Academy of Child Trauma Studies, and we are the training arm of Children's Advocacy Services of Greater St. Louis, and which is part of the psychology department at UMSL. So Kate and I, along with our colleagues, spend a lot of time involved in training projects across the state as we seek to try to as well increase access to evidence-based mental health services for children and families. So we're very excited about this Learning Collaborative. In the past 8 years, we've completed 14 of these projects, so this will be our 15th Learning Collaborative.
Wow.
And we've trained to this point about 1,400 people in trauma-focused cognitive behavioral therapy. So we're very excited about all of that and looking forward to meeting those of you who decide that you want to be part of this project and seeing what sort of impact we might be able to have across the state as we move forward. So our goals today are, we really want to make sure, if you're considering making the time commitment for this project, we want to make sure that you understand what trauma-focused cognitive behavioral therapy is and how good of a fit is it going to be for you as a provider or your organization or your community and the children and families that you serve. We want to make sure people understand what is a learning collaborative. Some of you may have been part of organizations that have done a learning collaborative before, but we want to make sure people understand that, as well as how you can put together a team and the application process. And then we're very excited as well. We've been getting lots of questions about the application and how that's going to work. So we'll walk you through that, but we're releasing the application today following the webinar. So if you have already signed up via email, Stephanie Lane will be sending out that information this afternoon, as well as giving you any follow-up pieces of information. So with that in mind, I'm going to go ahead and turn it over to Kate, who's going to walk us through sort of a brief overview of what TFCBT is, and we'll address some of the questions that were sent in along the way here.
Okay, so trauma-focused cognitive behavioral therapy is a very efficacious treatment for children and adolescents and their non-offending caregivers. We generally work with kids between the ages of 3 and 18, and it is a directive model. It's a directive CBT model where the therapist it's not a non-directive play therapy, but we're actually focusing the discussion and helping the child become desensitized to discussing their trauma. We focus on both trauma-focused skill building, so things like relaxation and affect, and we focus on exposure to the memories of the traumatic event that happened. Trauma exposure is really part of a lot of different trauma treatments, and it's certainly part of TFCBT. TFCBT is very well studied. It's sort of the gold standard child trauma treatment out there. It's really gaining a lot of momentum nationwide and worldwide as people see the evidence. It's just very compelling in terms of how efficacious it is. It's also helpful because it's a short-term model. We generally use, 8 to 16 sessions, and so kids get better quickly, and that feels really good for parents. It feels good for providers. It's very rewarding to see that progress. And so it just has a lot of research. So for those of you who are really interested in the research evidence, I recommend looking at the California Clearinghouse for Evidence-Based Practices. And that goes into, all of the different studies that have shown how effective TFCBT is. But we know that TFCBT is helpful not only in reducing symptoms of post-traumatic stress disorder, but also trauma-related depression, trauma-related anxiety, behavior problems, sexualized behaviors, and then things like cognitive distortions and feelings of guilt and blame and that sort of thing. Another really cool thing about TFCBT is that caregivers get better too, and caregivers are actually a big part of the treatment, and so we'll talk more about that, but it's neat to see them be able to support their child and learn some really strong parenting practices that will help the child at home and will help the child feel safe and more secure and able to practice their skills. And then partially as a result of that, the parents' depression decreases and the parents' feelings of guilt and blame. We address all of that in TFCBT, so it's really neat to watch. This is just a little bit more evidence or information about the evidence behind TFCBT, and you can see the link to the California Evidence-Based Clearinghouse on your slide. So again, I do recommend that you check that out if you have more questions about the research data. Okay, so like I said, ages 3 to 18, and we're looking at kids who have symptoms of post-traumatic stress. They do not have to meet full criteria for the disorder, so no worries about that. But we're looking at kids who had a trauma and then are having some symptoms and some difficulty adjusting. We know lots of people go through trauma and don't develop symptoms of traumatic stress, and this is for kids who do have some problems, as a result of that trauma. So we can address single acute traumas, like if a kid was in a car accident or a house fire, something like that. And we can also address more chronic complex trauma, like domestic violence that went on for years or sexual abuse by, a close family member. We can address multiple traumas. It doesn't have to be a really clean and easy trauma. Certainly at the Child Advocacy Center, we work with a lot of really messy cases and have good success with TFCBT. TFCBT is also helpful for traumatic grief, so that's where the trauma symptoms are impinging on the child's ability to move through the different, the grief cycle and those sorts of things. And we can use TFCBT in different settings. So we can do it, we've worked with clinicians who have been school-based, I think residential-based, community-based, all of those things. Now, I think each of those settings can provide some unique challenges, but we'll work with you to really to implement the model as faithfully as possible, given your unique setting. Okay, so like I said, 12 to 16 sessions. Sometimes it goes longer. It's not usually that much shorter, but it's a short-term treatment, and that's what's so helpful, is that we're not telling people their child had a trauma and now they're signing on to 2 years worth of
therapy for the rest of their lives.
Nothing like that. So it's really nice that we can get kids back to doing baseball practice after school and things like that, because we're able to move through the process quickly and get them back on the developmental trajectory. All right, and TFCBT can be just part of a treatment plan. You know, some of you might be providing outpatient services that are addressing a range of problems, and perhaps trauma would just be part of your treatment plan. So you would do TFCBT and then continue working with the child on, you know, maybe other, you know, ADHD or other types of symptomology. Mm-hmm. So we know that TFCBT, while it is a manualized treatment, there's a lot of room for creativity and for clinicians to use the things that you're already doing and using. And so if you do some play therapy, there's ways to incorporate play into TFCBT, or if you
art therapy.
Yeah, exactly. So we want people to be creative and to tailor interventions within TFCBT to your particular client. That's how it's going to be most effective. So if your client loves Teenage Mutant Ninja Turtles, you're going to use you're going to help them use the skills and base the skills around Teenage Mutant Ninja Turtles and play games, and so that it's really engaging for them and they're having fun and you're having fun.
And one of the questions actually that we get a lot as people are considering TFCBT, particularly if they have not used evidence-based practices, is we'll have people ask us for the manual. And so we like to be very clear up front, is that there's no manual that says you have to do these 10 things in session 1. So TFCBT is not a model where you're going to get a script that says, say this to the client, then say this to the client, then say this to the client. So it's really
That's a great point.
helping people like understand like these are the theoretical decision points of the model, and how do I apply this in a way that's like a good fit for my client.
That's a great point, because TFCBT is a manualized treatment, but it's not manualized to the degree that PCIT is, or another one like that. Yes. And the nice thing about TFCBT too, with the large research base that it has, it's been studied with a very diverse population and is currently being used all over the world, you know, sex trafficking victims in Africa, to suburban kids in, you know, Ohio.
Rural context.
Yeah, a lot of different settings. It's proven really effective with a lot of different populations. So there's an adaptation for American Indians. There's an adaptation for, you know, all sorts of different groups, and that's been really fun. So the practice is an acronym that we use, or the developers have used to just easily remember the different components of TFCBT. So we start off with psychoeducation and parenting work, because we know that, you know, parents are the number one predictor of treatment success, the involvement of at least one supportive caregiver. So we work with a caregiver to provide some environmental safety for the child and give them the space to really start healing. We also provide psychoeducation to the child and the parent, and we know that psychoeducation is so helpful for people who might be feeling like they're the only one who's having these problems or who's struggling in this way, to really give them information that is reassuring and helps normalize what's going on for them. Then we teach relaxation skills to the child. We also teach the skills to the caregiver so that they can coach the child in using those skills at home. And meanwhile, during all of these components, we try to keep it really trauma focused. So we're talking about trauma in every single session. But we are increasing the child's skills in the beginning portion of treatment. So we're teaching them the relaxation skills, and then we move into affect, expression, and regulation. So we might talk about feelings people have when they've been through trauma and how they can manage those feelings. Then we do some cognitive coping about how thoughts and feelings and behaviors are really connected and how you can use those to change how you're feeling and your behaviors. We do, next is the trauma narration, where we have the child describe the trauma in detail to desensitize the child to those memories. And it's really powerful, and it's my favorite part of treatment, and kids really talk about, at the end of treatment, how helpful that particular component was. We do in vivo gradual exposure if, following the trauma narrative, they're still reactive to innocuous trauma cues. That's when we might create a plan for them to become desensitized to those reminders. Like if they were sexually abused in a basement and they're afraid to go down into any basement, well, we'll help them work up to the ability to be able to do that. We do conjoint parent-child sessions throughout the model, and help the parent and the child learn to talk about trauma together, and for the parent to be able to listen to the child's story and be able to support them through that it's been really neat. Now, in some settings, there might not be a caregiver available, and this comes up for some of the people that we consult with and we work with you. I mean, obviously for the benefit of the child, we want to have a caregiver involved. Sometimes that's not possible. It could be that the caregiver doesn't believe the child, or for whatever reason there's no caregiver available, and that's not a rule out. So just so that for the record, we'll still work with you, and you can still learn the model and implement the model. So that's neat. And then the last component is ensuring safety in future development. And we know that kids who've been through trauma are at risk for re-victimization, so we want to take the time to teach them some skills to prevent that if possible. And then also to talk about what life will be like for the child in the future. They have this trauma history, that's not going to go away, but we would still expect them to have healthy relationships, have healthy sexual relationships, those sorts of things. And so let's actually talk about that and make a plan for future trauma reminders, that sort of thing.
And that's the part that we hear a lot of feedback from clinicians and brokers and other people that are part of the training, is what they really enjoy about TFCBT and this whole process is watching not only the child, but the whole family's sort of post-traumatic growth of moving from kind of the chaos that can be the experience of trauma forward into the future.
Yeah, and then here's just more information about the different components. So the psychoeducation, parenting, relaxation, affective work, and the cognitive coping, that's sort of the foundational skill building parts, still trauma focused, but that's where we're learning skills that will help propel the child through the trauma narration and be helpful for the child in stabilizing them from day one. We do incorporate gradual exposure, so we're talking about trauma. We're just not having the child describe their specific trauma experience until we get to the second part of treatment, the TICE, where we do the trauma narration, the in vivo work, and then start planning for the future. Here's just another representation of the practice components. You can see we start with education and skill building and move through trauma processing, but the gradual exposure is really a part of it from the beginning. In the caregiver, I really emphasize the caregiver component because for a lot of child therapists, working with a caregiver is, might be anxiety provoking or not the part that you're most looking forward to, but it's so critical for a child's success. And whenever possible, we really do like to use the caregiver.
Got it. Yeah, so with the caregiver part, that was also something to consider as far as goodness of fit for TFCBT to your practice. So sometimes we'll get caregivers that think that they can just drop their kid off for treatment and then go run a few errands and come back and pick the kids up. So this is a sort of treatment model that does need the parents to be there. And I mean, we've gone out to the parking lot to ask parents to come in and things like that. So just know that that might be a piece of TFCBT. Depending on your context of practice, that might feel a little bit different.
Yeah. But yet, I think it's really rewarding in the end. And we will help work with you every step of the way to feel more comfortable using those caregivers to help the kid meet their goals.
Yeah. So right now that we have talked a little bit about what TFCBT is, and so we're going to check in to see if those of you on the webinar have any specific questions. We will be getting into more sort of nuanced details of this community-based learning collaborative approach, but first we wanted to kind of check in and see if there were specific questions about TFCBT in general. So a question that we get a lot is, what happens if I have a child who's self-injuring or has expressed some suicidal ideation? Can they still be appropriate for TFCBT? And the answer to that is that we will work with you and coach you with that, but that some suicidal ideation or some self-injurious behaviors does not make a child a rule out for TFCBT. We really want to make sure that the child is stabilized, and often those clients can really benefit, especially from the PRAC component, which is the stabilization portion of TFCBT. And then we sort of monitor to see to what degree can the child tolerate the direct gradual exposure work there as well. And one of the things, Kate mentioned some of the like residential or sort of different contexts of practice. And one of the things we really enjoy about the full learning collaborative approach is that we will have a total of 6 days of training for the clinical track, which allows us to be able to have specific topics or questions related to TFCBT adaptations that we can address over the course of training. So sometimes if we have a group where they have lots of really young children on their caseloads, we might do a special topic related to TFCBT adaptations for young children or expressive ways of addressing trauma within TFCBT or things like that. So just know that once we get through the first 2-day training, we are able to really customize the training experience for our population of training participants, which is really fun.
Yeah,
so, Kelly, are there any questions that have come in so far this morning?
No questions as yet. We had a little difficulty at the beginning, so if people are watching, refresh your browser, and then I was just going to tell you to watch your hair on the microphone. It makes a little noise too, so
Okay.
that's all we have at the moment.
All right, great. Well, then we're going to go ahead and move on and start getting to some of the more nitty-gritty of this training opportunity and what some of those overall goals are. So for this learning collaborative, our overall goal is we really want to improve outcomes for the children and families that we serve in Missouri. We feel very strongly that as much as we wish we could end all the bad things that happen to kids, that's not necessarily a realistic goal, but we really do think that we can increase the response across the state from everyone, regardless of what service sector they're in, who interface with children and families who've been impacted by trauma. So to that end, we both need to increase the number of evidence-based providers who can respond appropriately clinically across the state. So we need to be screening and assessing children and then also implementing TFCBT with fidelity. And in addition, we want to do this in a sustainable way. So I know Kate and I both have, and I'm sure anyone professionally has gone to trainings and loved the training and been really excited about it and finished the training on a Friday, and by the time they get back to the office on Monday, they sort of forget what this was all about and it kind of falls by the wayside.
We do have a question that just came in.
Oh, great.
A person is asking, does the client have a workbook to complete?
No, there's no workbook in TFCBT. That's a great question.
So sometimes we will have clients do homework or practice assignments between sessions, but that's really at the discretion of the provider and kind of what the client's goals are.
Exactly. There is I want to clarify, there is a TFCBT workbook that I've seen, but that workbook isn't meant to be done
with every client, every session.
In a structured way, and that's the treatment. It's more you can use some of the worksheets in the workbook to support the different components, depending on the kid's age and desire to do worksheets, that sort of thing.
Yeah, and actually, worksheets, one of the things that is also a collaborative goal that's not on the slide, but any of our training participants have access to an online learning community where we have shared resources so that if Kate has a handout that was really effective for teaching some affect expression for her client, she can upload that and I can download that to sort of help save time as a clinician from having to recreate the wheel. So in addition to sort of increasing the number of clinicians who provide treatment, we can train clinicians all we want, but if clinicians are not getting referrals, they will be unsuccessful in implementing TFCBT and serving children and families. And to that end, this learning opportunity is what is called a community-based learning collaborative that helps develop a community-level response for children who've been impacted by trauma. So a little more information about that. Within a community-based learning collaborative, the goal becomes a trauma-informed system of care in which all professionals interfacing with children are both going to recognize trauma, understand how does trauma impact my treatment planning, how are we being trauma sensitive in terms of what are we asking the caregiver to do, what are we asking the child to do, how many appointments is the family going to school, going to have at any one period of time. And also part of that process is we need to have everyone in the service sector understand what is my specific mandate as a mental health professional versus my mandate as the deputy juvenile officer or my mandate as a forensic interviewer. because we need to understand each other's mandates in order to really provide the most coordinated care for our families. So the definition from the National Child Traumatic Stress Network of a trauma-informed system of care is included here on this slide. The pieces that really we want to highlight here are the idea that responding to children impacted by trauma is the responsibility of like all grown-ups. So it's not just child protection, it's not law enforcement, it's not mental health. And I think a lot of times we get tired or we get busy and we want to say like, that's not my problem, like that's the court's problem, or that's the school problem, that's someone else's job. And we really are trying to sort of move beyond that to figure out how we can act in collaboration to promote recovery and resiliency for children and to sort of stop passing the buck. Because as Kate just highlighted, we've got really good treatment. Like PTSD is actually a really great mental health diagnosis to have because there is such effective treatment for it. We just need to make sure that we can get kids into that treatment and also not have other things in the system continue to add secondary adversities that are going to delay treatment outcomes. So up on your screen is a collaborative overview where there's lots of boxes. You don't need to really worry about what is in each of them right now. But what we want to highlight is, I'm not sure if you could see that there on the screen or not, but this collaborative process to increase our system level response and the whole community approach actually highlights the different training tracks that we have as part of our learning collaborative. So we will have our TFCBT clinicians, so those are going to be our licensed mental health people that will come to 3 learning sessions over the course of a year. We also have clinical supervisors as well as senior leaders. And we're going to go into the definitions of who each of these people are in a little while. And then we also have our brokers of service or our multidisciplinary team members that collaboratively across these 4 training tracks for our learning sessions that are going to be in April, July, and October. So we'll come together 3 separate times over the course of the year for each of these groups to work on what is it that I need to do to better serve children who are impacted by trauma. So to break that down a little bit more, what we're going to be doing is coming together in April, and the clinicians will get their information about TFCBT, brokers of service will get information about how do I screen and refer children and better understand how I can be trauma sensitive within my own work. We call that learning session 1. Then we say, go out and try it, and then send everyone back out into their practice, and you will start implementing the things that you have learned at the training, and that is what we call our first action period. So that during that time, everyone participating in the training will have web consultation with me and Kate and Matt and some other members of our MOAX training team. Then we come back together and learn more information and sort of share information. So if I'm on a team in Joplin and Kate is on a team in Jefferson City, then we can come back together and say, hey, this is how things were going for me. Or I could ask Kate and say, how did you streamline your referral process? So that piece really becomes a fun opportunity for people to share resources and network and things like that across the state. And in case you're curious about why we are doing this learning collaborative approach, there's really compelling research from implementation science that a one and done training isn't enough to embed and then sustain a practice within an organization. And so this learning collaborative model was developed by the Institutes of Health and really has great outcomes in terms of people picking up a new learning and implementing it and actually sustaining this change over the course of their professional career. So with that, I referenced earlier our different training track options. And so I'm going to now walk through what each of the 4 training tracks are. And just to sort of also keep your ear open to this, the application process is going to be a team-based application of 6 to 8 people from around your community. So it might be, we define community pretty broadly, and we'll walk you through some examples in a little while. So for the application, you will need to have someone in each of these roles, and only applications that are, have someone in each role will be considered for inclusion in this project. So our senior leaders are going to be our kind of key decision makers, executive directors, leaders within an organization. And the point that we really like to highlight, like these are people who need to have the decision-making capacities to either alter workflow or alter organizational policies to allow for screening and referral of trauma cases, or changes that need to happen in order, if it's a clinician side of things, to be able to actually see TFCBT clients. So we've worked with senior leaders before where perhaps they're in an agency that's very underserved in terms of number of mental health providers. So if clinicians previously had rules that you could only see clients twice a month, the senior leader had to change that rule to be able to say, no, you can see clients every week if they're a TFCBT client. So it resulted in a change of workflow. Our senior leaders will be coming to Jeff City for a half-day training in April. We're going to be talking about TFCBT, how you can integrate TFCBT delivery into other parts of your organization, what structural support is needed, as well as fidelity and sustainability. If you are in that senior leader role, you are welcome to come to as much of the training as you want to. The only required part is that first half-day face-to-face training, but we recommend that you be at as much of the training as you can to support your team and participate in those consultation calls. Then we have our brokers of service, and those are going to be our sort of key stakeholders. So anyone who is interfacing with a child or family who's been impacted by trauma, where they identify and help triage children into appropriate services. And so this is very much an interdisciplinary group of people. This is going to vary a lot from sort of community to community about who these people are and who needs to be at the table. So their training topics include what are the essential elements of a trauma-informed system of care, how do I recognize and respond to those needs, how do I do advocacy, how do I triage and make referrals, as well as treatment planning. In addition to this, we'll be using what's called a problem-based learning approach to making treatment team decisions for children and families as well. So this is something that in the past we've had school resource officers, we've had teachers, we've had school counselors, social workers, a lot of children's division staff, court staff, we've had guardian ad litems, we had a judge once who participated. So it really can depend on who makes most sense for your team to then help bring sort of that community piece together. So as far as our clinicians, everyone who participates on our clinician track will be meeting the training requirements set forth by the developers of TFCBT. So our clinicians and our clinical supervisors, if they choose to, will get all the information they need to be a roster provider of TFCBT in the state of Missouri, and they'll be prepared to take the national TFCBT certification exam as well. So because of that, we do have some stricter requirements of who is appropriate to be on the clinician track, and this is not decided by us, this is decided by the developers of the model. So we're a little bit limited in that way there. So with that in mind, our clinicians need to be master's level or higher mental health professionals, which discipline you're in doesn't matter, who will be trained in TFCBT and begin delivering TFCBT within your community. So with that in mind, the clinicians do not have to be fully licensed. So that was a number of questions that we had. So if someone is provisionally licensed or in the process of being provisionally licensed, they are welcome to attend and join in. You cannot be rostered, though, until you are fully licensed. So if someone is provisionally licensed, we usually recommend that you go through the whole training process and then just send us a note or send us a copy of your license at the point that you're fully licensed. So our clinicians will be receiving in-depth training in the TFCBT components. One of the things that we spend a lot of time emphasizing is actually trauma-focused assessment and treatment planning. And a wonderful thing that we're able to provide as part of this collaborative process is that clinicians will receive copies of the assessment measures, so everything you need for assessment is included. Senior leaders, we're also very excited that the Missouri Children's Trauma Network will be providing electronic copies of scoring software, which if you've ever looked into that before is a huge cost. So they're providing that in order to sort of ease the burden of having to score assessment measures. So we will be going through assessment, treatment planning, how we can apply TFCBT to specific cases. And one of the things that's really nice as a clinician is that at learning sessions 2 or 3, you'll have opportunities to bring your TFCBT cases to the training, and then we do what we call workshopping cases. So you'll have the opportunity to present and consult with other people from across the state about specific stuck points, which is a really nice opportunity to directly practice and incorporate new learning into the process. So we get a lot of good feedback about that.
I don't know if this is a good opportunity for me to talk a little bit about the consultation calls.
Oh, yeah.
But they are really designed to be supportive and helpful, so to really help you as you're implementing this model and learning the model to get that extra support. They are required by the developer. So if you want to get certified as a TFCBT provider in any state in the country, you'll need to do the consultation calls. So we provide those as part of the Learning Collaborative. And you'll make formal case presentations on the calls, but it's done in a really supportive way. So we're not going to, be yelling at you that you're not doing it right or do it differently. We know these cases are hard. Trauma cases are hard, and we just want to be there to support you. And, I've had calls where the participants really get to know each other well on the calls, and then it's just adding to the support that you have in your community and across the state. It's been neat to see the relationships develop, not only between me and the participants, but between the participants themselves. And so I can see they'll send emails back and forth like, hey, I was thinking of the client you presented on last month, saw this resource, and that's been really fun. So the calls are enjoyable. They're not supposed to be a drag or labor intensive or stressful. They're supposed to be just fun and helpful. And I really enjoy them. So hopefully you all will too.
Yeah, and I was just going to say, we actually have people say like the consultation calls are one of people's favorite parts. And we've had groups before that continue to meet as a group after the consultation ends because they enjoy that support. And in case you're starting to wonder about when are the calls and what happens if I can't make the calls and all of those things, we'll be doing 5 different consultation calls for this training for clinicians, so that we're able to take into account your schedule and which is the time that might be best and help best fit into your schedule. So we try to be responsive to that, so we don't want people to be preemptively worried about that part.
Correct.
So then we actually had a couple questions about our supervisor track ahead of time, so hopefully we can address those questions here. So our TFCBT supervisors are sometimes they're sort of clinical managers who have direct report staff. Sometimes they're people who have more experience with TFCBT and they do some informal coaching and things like that. As you are considering putting a team together, if you're considering being in the supervisor role, we mean supervisor very generally, and for the coach of for the purpose of this collaborative, we really need that supervisor to be the person who's kind of coaching and motivating other people on the team and helping remind people of, hey, we need you to come to the training, or, Kate, have you picked up a TFCBT client yet? So the supervisor role for the purposes of the Learning Collaborative is not required to be legal clinical supervision for the purpose of licensure. And it does not have to be formal, direct report relationships. So at a minimum, we need whoever is in that supervisor role to be the person to say, I will make sure people are doing assessment measures. I will make sure that people on my team are starting to pick up TFCBT cases and participating in consultation webinars and things like that.
Yeah. So having supervisors is really designed to just embed TFCBT within the agency, just like we have with the senior leaders.
So our supervisors will do a full day of training with us in April, July, and then October. It's the day before the 2-day training that the brokers and clinicians go to. Some of the topics are included here. I think a lot of it really focuses on, if I am coaching or supervising in TFCBT, what are the decision points that I need to use to help me know how to feel comfortable with supervision within an evidence-based practice rather than supervision more broadly. In addition, clinicians sometimes feel anxious about assessment measures, so we want to make sure that the supervisors feel like really confident about how to coach or answer questions or things like that. And one of the things that we've heard good feedback about is that we have the supervisors come a day early, because then they kind of have a preview of what's coming for the clinicians and other people on their team. And then if you're in the supervisor track, I really liked it when I got to do it, because then you get to practice the skills like the next day. So if I learn assessment stuff and then I'm kind of coaching Kate with it and I run into a stuck point, then I've got other people there like right away who can help me answer those questions. So then I feel more confident doing it after the training has ended. Supervisors also will be doing separate consultation calls with me, I think, over the course of the year. And then supervisors, if they are not already rostered providers of TFCBT, can also go through that process as well. So it's sort of up to the discretion of the supervisor. So that is a lot of information about these different roles. For all training participants, we expect that you will attend all of the learning sessions, that you'll participate in the consultation calls, and sort of also that you will be willing to say, I am willing to sort of do my part, even if it's sometimes hard, to really help improve this broader system of service for children and families. So these next few slides I'm going to move through a little bit quickly, because we want to make sure that we get time to talk to the application process. Yeah, we've got a question here.
Yeah, I have a couple questions that may pertain to what you were just talking about, so I wanted to get those in. So one of them is, our clinicians also provide case management. Can they serve as representatives on both roles, the clinician and brokers of service?
Oh, that's a great question. So we do ask that you have to choose either clinician or broker of service, which is mostly because those trainings happen concurrently, so you can't physically be in two places at once. So, but I will say that one of the things we have as well that we haven't really talked about is we've got activities that happen across all training tracks. So there's a lot of like shared information that happens. So I think we definitely take a holistic view of the clinician track. So it does include advocacy and things like that.
Okay, we had another one. Are the collaborative team members employed by the same agency or organization, or can member teams be organized across agencies or private practices?
Such a great question.
So actually, no, you don't have to work in the same agency. And we've had teams before where clinicians partnered with Children's Division or DJOs or other types of community mental health sort of case managers, things like that. And it's worked really, really well. And then they really develop, even though they don't work together, they develop really close collaborative relationships, and we're sort of linking service systems. So we're linking the TFCBT provider with community mental health or court or children's division, what have you.
Yeah, and we intentionally don't put restrictions on that, because we really want this to be what's going to make the most sense. And like what might make the most sense for a group in Kansas City might not make the most sense for a group who's in Warrensburg. So, you know, we really want to be responsive with that. And what I will say, we have it in the slides, but after today, if you're thinking about putting together a team, I really enjoy working with people to sort of think through, this is kind of what I was thinking. Does this make sense? Do you have any other ideas about how I might want to assemble the team? So these next slides I'm going to go through very quickly so we can get to more of the team information. After you get through the application process, and if your team is selected, you get this huge PDF document that has all of the training dates, all of the times, all of the consultation calls. So you don't need to be overly concerned about understanding all the nitty-gritty of the logistics now. Some really fast logistics that we haven't told you necessarily yet is that all of the trainings are going to be in Jefferson City, and that the training is free of cost, which is amazing. So the funding is actually funded by the Missouri State Legislature and comes to us through the Missouri Department of Mental Health, which we are so grateful for. So all of the training expenses are covered. There's the possibility, that we don't quite know yet, that there could be some stipends after the training concludes to help offset travel costs. So if you're thinking about like organizationally, what would the costs be? The costs are really the travel to and from Jefferson City, as well as then the hotel costs. We do have lunch included for the training. So,
and I've been impressed with that. The lodging costs are not bad in Jefferson City. It's not like we're going to New York City or
Yep.
major.
Exactly. And so generally what we are asking is for senior leaders, we really need these people to be buying into sort of the mission and value and bringing this attitude of like, this is what we are going to be doing, and to help motivate and coach their team. So with that in mind, we've included these pieces here of expectations for senior leaders. For our brokers of service, they will be coming to Jefferson City for 2 days in April, 1 day in July, and 1 day in October. Our brokers, as well as our clinicians and supervisors, we also ask that you complete monthly data reports for us. And the data reports are so important because they allow us to monitor how people are doing with the process, and they help us catch like where are places people might be having trouble. And in addition, this data is really like why we have the funding, because we're able to compile the data and take it back to the Missouri State Legislature at the end of this project to say, these are the improvements we've seen in services for children impacted by trauma across the state of Missouri. I think our last collaboration with the Missouri Children's Trauma Network, I think it was about like 471 children had been served by the project, and I think we had about 85% of children showed clinical increases or improvements in PTSD symptomology, which is wonderful. So again, these are our broker of services. For our clinicians, the clinicians would be attending the 6 days of training. There's some pre-work before the training that we will fill you in on at a later point, as well as completing the web conferences and assessment measures. The biggest thing for a clinician, if you do want to become rostered, is that you will need to complete at least one TFCBT case by the end of April in 2020. So if you're thinking about, is this a good fit for me? Does it fit within my practice? What do I need to do to be on track for rostering? That's really the biggest thing, is you've got to complete at least one case by the end of the project. So our supervisors will complete all of the clinician requirements, as well as attend these supervision trainings and consultations. So again, this is just to orient you. Hopefully this graphic now makes some more sense, that we've talked through it a little bit more, but that this whole team approach really allows us to embed TFCBT within the fabric of communities for whatever makes the most sense with the community. And so with that, we're going to spend a little bit more time talking about some logistics of these collaborative teams so that everyone knows kind of what to expect. So we are asking that everyone consider who are sort of the natural partnerships within my community to create a team of about 6 to 8 people. Ideally, teams will have, so this is what you have to apply. We need at least one senior leader, at least one supervisor, and you can have the same person in that role if necessary. We need at least 2 clinicians and at least 2 of the 2 brokers of service. And in case you're like, these numbers seem kind of arbitrary, it's really hard to be the lone wolf, like in any endeavor. And what we have just seen over the years is that if someone doesn't at least have a buddy as they are learning something new who can hold them accountable, it ends up sort of falling by the wayside. So thinking about who your collaborative team might be, we wanted to introduce you to Thelma the therapist, who's thinking TFCBT sounds really great, and I want to put together a team for this process. So she thinks to herself, who in my community do I already collaborate with or refer to related to trauma cases? So she thinks it makes sense for me to include, I'm in this organization, let me get my executive director on board. So in comes our senior leader, Shannon. So then she thinks, hey, my actual clinical supervisor is Sherry, so let me tell her about this and have her included. So this would be an example of someone that has a couple people within their organization who they might need to include. So then she thinks about, there's this other counselor who's really cares about trauma, let's include her, as well as, I get a lot of referrals from Charlie, so why don't I go ahead and reach out to him to say, hey, this opportunity is happening. We already do a lot of referrals back and forth. This might help the process. In addition, they also realize that Danny is a DJO that often refers cases as well. So this is an example of someone thinking about who do I already have collaborative relationships with, and how can I include them in this process? So we've included a handout for you that you should have received over email that includes some of these questions that can help if you're kind of feeling stuck about who might be in my team. So some of those could be, who within my organization do I need to be on the team? And we often encourage people to think about who needs to be on the team for this to be successful. Who are people in my region that sort of help identify children and triage them into services? So is there anyone from Children's Division, a guardian ad litem, CASA workers, health professionals, advocates, school staff? Who might those people be? And then we also encourage people to think not only about, are there pre-existing relationships that I would like to strengthen, but are there relationships where you're feeling like in my community there's odd dynamics between service sector A and service sector B, where if we all got to know each other better and sort of all receive this training, that this would really strengthen things sort of within my community. So not necessarily like a weak link, but just something, an area where you're like, this would really be improved if. In addition, we want people to think about, are there sort of geographic gaps in terms of service sectors where if I incorporated this or things like that, things could be better. So we had a group where Children's Division was saying, you know, we've got this one county where we have providers, but no one's an evidence-based practice provider for trauma cases. So Children's Division reached out to sort of general mental health people that they knew of and invited them to participate, so then Children's Division could have more options of evidence-based providers. So to look at this again, another way to think about this is an example of a caseworker where the caseworker Charlie works with Tammy in a county where there is no evidence-based provider. And so Tammy does have a really wonderful therapist. She's just not trained in an evidence-based practice. So again, just like as I was saying, Charlie goes ahead, calls up Connie and says, hey, do you want to be part of the TFCBT team? And Connie is like, yes, this would be amazing and make my practice better. So then the counselor Connie goes ahead and invites the DJO, who's part of the case, and says, hey, this would make sense if I'm doing this. Let's go ahead and have the DJO join in. And then over the course of the collaborative, Connie is able to provide treatment to Tammy, but she also is able to work with Charlie to help arrange transportation, and then work with Danny to help decrease sort of school triggers that were going on, so that Tammy can again go to school and really reduce what we were talking about earlier of some of the secondary adversities in the system that might make delivery of a mental health service tricky. So by the end of treatment, Tammy can go back to just kind of being Tammy and going to school. So this is sort of our ideal, clearly very orchestrated example of a perfect world response where getting all these people together as part of the collaborative process is going to help improve outcomes for children impacted by trauma. And again, just to remind you is of like why this is necessary, is that without this, the counselor may end up needing to close Tammy's case because she's not coming to sessions regularly. And if she's not going to school, as much as Danny feels for Tammy, he might have to go ahead and make a truancy referral. And then because of all of this, even if the caseworker feels very strongly about the quality of Tammy's placement, if her behaviors are de-escalating and she's not going to school, then they might have to move her to a higher level of care, which we know is not ideal either for Tammy, or also then societally can become more expensive and not as good of a use of resources. So again, we walk through that example rather quickly to just highlight how important it is for this team-based approach. We are happy to help consult with you about how to put your teams together and what that would look like. And in case you're wondering about what actually happens next is, following the webinar, we will be sending out the application link. Our application is going to be an electronic application that you can fill out online. It's not very long. There's two parts of it. There is going to be the team part that will be completed by the senior leader. That includes information about who everyone is on your team and what roles they're going to be in. And then each individual person also has a portion that they complete themselves as well. So if I was doing a team of 8 people, all 8 of us would complete an application. I, as a senior leader, would complete the senior leader portion, and then the remaining 7 people would complete the individual portion. We can help with that process as well. So the applications are due by 5 p.m. on Friday, February 1st. And the selection committee will work as quickly as possible to evaluate the applications and let people know if they are accepted to the training. We had over 200 people sign up for this webinar today. and our training capacity is about 110 people, or a total of about 50 clinicians. So we are anticipating that this will be a competitive application process. In case you're wondering about application criteria, the spirit of the project is really looking to expand capacity across the state. And so current existing geographic access to TFCBT for children and teens is going to be probably the biggest consideration in terms of what teams are selected, because we want to really increase access across the whole state, not just sort of specific regions. So the application information is here with the link to that. You will also be receiving an email where you can just click on the link directly. You can start the application, but you can also come back to it, so you don't need to do it all in one setting. And if you want to see a paper copy of the application as well, we can get that out to you as well for follow-up. So we are hopeful that at this point you are excited about applying. Hopefully this webinar has been helpful to you in terms of figuring out, is this a good fit for me or not? If you're thinking the Learning Collaborative is a bigger time investment than what you want to make or have the capacity to give right now, that's totally fine. And we do offer some other options for training in TFCBT that we can talk about separately later. We did want to go ahead and include some quotations from those who've participated in this process before, and then we will be finishing with any other questions you have. So one quote was, "Great experience. The training and process expanded my clinical knowledge and skills. We're better able to serve children and teens." A broker of service said, "Because of the training, we had a school emergency, and I was able to develop a plan to reduce the stress on the children, and the administration followed that plan. Otherwise, I would not have been prepared." And in addition, children and families have wonderful things to say about TFCBT. So we had a 10-year-old girl who said, "Now I know that everything will be okay with my future. I'm not scared anymore." We had an 8-year-old boy say, "I learned that pushing away what happened will make it worse. I can talk about it and it's not scary." And then we had a caregiver say, "So much has changed. She's engaged, expressive, and happy. She uses her skills and teaches them to friends. I feel like we have our daughter back, and I'm forever grateful."
Well, thank you so much for participating. Amy and I are super excited about the Learning Collaborative. These are a lot of fun. We always enjoy making relationships with the participants and seeing participants develop relationships with each other. So I encourage you to apply.
Yeah, so now we will go ahead and take any questions that we might have. A question that we haven't addressed yet is CEUs, and yes, you will be getting CEUs. We have not registered our training agendas yet with the Missouri Children Trauma Network, so I can't tell you how many CEUs it will be.
A lot.
But it'll be a lot, so hopefully that helps for those of you with license renewals coming up. I think we addressed questions about certification. Are there any other questions that are coming in? Kelly?
Yeah, we have several.
Great.
Kind of on the lines, folks are asking if you have the dates for April, July, and October. Do you have dates yet scheduled?
We do have dates, and they are in your training slides. Let me go ahead and flip back to those. So the April dates for clinicians are the 4th and 5th of April, the 18th and 19th of July, and then the 3rd and 4th of October.
Okay. And another question is, do all members of the team, brokers of service, clinicians, et cetera, need to be working on the same case?
Oh, that's an awesome question. Nope, they don't all need to be working on the same case.
Well, that was an easy answer.
Yeah.
The next question is, what happens if some team members do not fulfill their commitment? Is the rest of the team still able to continue?
Yes, they are. We hope that all the team members will stay committed and cohesive, but we understand people move, people have babies, things happen.
And this one, I think you did mention, and I don't recall what you said, so I'll ask it anyway.
Sure.
How many teams do you think will be accepted?
Oh, that's a great question. So we actually don't have an answer to that question. We have, with the training space and funding that we have we know how many people in each role we have space for, if that makes sense. So what we would encourage you to do is sort of to put together your ideal team size, and then based on the number of people that each team wants to send, that will determine how many teams we have. I would say we often have between 8 to 12 teams included.
Okay. Another question is, would a residential setting be a good fit for the program? We have directors, therapists, case managers, and work with agencies such as Children's Division and Division of Youth Services.
Yeah, we've worked with clinicians at residential programs before. Definitely you can implement the model. I will say, in order to be certified or rostered, you do have to have at least one case that's with a caregiver. But we can sometimes be creative in how we conceptualize caregiver, and sometimes there's residential care workers that we can use, things like that. But yes, we can definitely accept teams that are residentially based.
Yeah, and I think something to think about for residential teams is how long your typical length of stay is. So we've worked with some like inpatient hospitalization settings where they really have kids for 4 or 5 nights is kind of their usual length of stay, which is obviously going to be too short to do TFCPT. So that's something to consider is, am I going to be able to do a couple sessions of assessment plus at least 12 to 16-ish sessions?
And I think you did address this one, but they're asking where the trainings will be held, and I think you mentioned Jefferson City, but...
Yeah, so the trainings, we've got amazing training space,
really
courtesy of the Missouri Coalition for Community Behavioral Health Care in Jefferson City. I'm, of course, not remembering their address off the top of my head, but we will get you all of that information. So it's very
beautiful
comfortable,
space.
beautiful space.
And that's all we have questions at the moment. Is there anything you want to wrap up with, and then I'll check again to see if we get anything else?
No, I just want to say thank you to everyone who's participated in the webinar, who's expressed interest.
Yeah, we are so, I mentioned earlier how many people have signed up, and we really appreciate your time as well as all the work that you all do on behalf of children and families in Missouri. That's huge. And even just the number of people who signed up for today is actually also like really helpful for us in the Missouri Children's Trauma Network to continue lobbying and advocacy efforts of increased and sustained funding for professionals serving children impacted by trauma. So thank you, and we hope everyone has a great rest of their day and weekend, and that if those of you are in areas where there's lots of snow coming, we hope all goes well.
Stay warm.
Stay warm. Thank
you.